Bismillahirrahmanirrahim. Assalamu alaikum. I am Professor Dr. Javed Iqbal FAROOQI, and you are watching my YouTube channel, Medicine Made Easy. Over the last 3 years, we have witnessed a paradigm shift in the global and regional approach to managing chronic hepatitis B disease. With the publication of new international guidelines, the treatment landscape is evolving rapidly, and as practicing clinicians, we need to stay one step ahead. In this vlog, I shall be discussing a new algorithm of when to start and when to stop antiviral therapy for hepatitis B. This algorithm is based on the updated versions of hepatitis B guidelines from AACLD, APASL, Chinese, WHO, and EASL. And what all of this means for clinical practice in Pakistan. So if you are managing patients with hepatitis B, whether in a public hospital, private clinic, or academic setting, this algorithm is for you. Let's dive into the science, evidence, and practical implications together. Bismillahirrahmanirrahim. Hepatitis B treatment algorithm 2025 and beyond. When a patient is found to be HBs antigen positive, then the next question comes in mind: when to start antiviral treatment and when to stop antiviral treatment. These are the two main questions which comes in mind. And in today's vlog, we shall try to answer these two questions in the light of recently published guidelines. We know there have been a plethora of guidelines over last 2 decades or so. Almost every year, new guideline is published from one of the 4 major liver societies, the APASL, the EASL, the WHO, and AACLD. And during the last 3 years, we had Chinese guidelines in 2023. Then in 2024, we had WHO guidelines, and now we have EASL guidelines. And the algorithm which I am sharing with you regarding starting antiviral treatment and then stopping antiviral treatment is in the light of these 3 main recent guidelines. So when a patient is found to be HBs antigen positive, so whether we should treat this patient or we should not treat this patient, this decision is based upon 3 main steps. Step number 1, step number 2, and step number 3. And today we shall find the answers for these 2 questions, whether to start treatment or don't start treatment. In the step number 1, what we do, it is important to take the history and clinical examination of the patient to see is there any evidence of cirrhosis and its complications. Then the next is the abdominal ultrasound to see is there any evidence of cirrhosis, portal hypertension, or liver mass. Then some non-invasive tests like EPRI, FIP4, FABROSCAN, and we divide the liver status regarding fibrosis into the one with insignificant fibrosis, F0, F1, then significant fibrosis, F2 and F3, and then cirrhosis, F4. And the another test is then HBV DNA quantitative PCR, and we see whether it is detected or not detected. If detected, then what's the viral load? If it's more than 2000 or less than 2000 international units per ml. And the last important test is the serum ALT. The upper limit of ALT, what we take here in Pakistan, is 35 for male, the men and boys, and 25 for female. So in the first step, these few basic data or evaluation is done. And then on the basis of this data, we enter the step number 2. And what is that step number 2? If this data reveals that the patient has got cirrhotic liver, F4, or the patient has got HCC, or the patient is in liver failure, or the patient has undergone liver transplant, or if there is any chance of reactivation of hepatitis B infection, like in case patient needs chemotherapy, immunotherapy, or targeted therapy. So these two scenarios, these are the red flags, or these are the indications that now we should start this patient on treatment. So any one of these two scenarios, not necessarily that all should be present. If your patient's liver is cirrhotic, if he is cirrhosis, if he has got tumor, if he has got liver failure, or if he has undergone liver transplant, or to go under liver transplant, or if he needs chemotherapy, immunotherapy, targeted therapy. So any one of these present, you start this patient on antiviral treatment. Clear? What about if none of these is present? What to do then? In the first step, you have done all this evaluation and you have got this data in your hand. And in the step 2, there's nothing like this that you start needs treatment. And remember, when you have got these two scenarios, that irrespective of the viral load and irrespective of the ALT levels, PCR may be negative, PCR may be just detected, PCR may be high viral load, or the ALT may be normal or raised, whatever the ALT level is, whatever the PCR level is, you need to start this patient on treatment. But when these two conditions or these two scenarios are not present, so what you do then? In that case, here comes the role of viral load as well as ALT levels. So you can put your patient may belong to one of these 5 groups. What are those 5 groups? One is when the viral load is more than 2000 and the ALT is raised. This is one group. Second group comes when the PCR is undetected. And the ALT level may be any level. It may be normal, it may be raised. So in the first step, if your patient falls in the group where the viral load is more than 2000, ALT is more than upper limit normal. Again, remember, we have crossed this step 2 and now we are in step 3. If your patient has got these two features or falls in this group, this patient needs antiviral treatment. Okay, so in the absence of liver cirrhosis, HCC, liver failure, liver transplant, or chance of reactivation, then decision is done by the viral load and the ALT. Viral load more than 2000, ALT raised, you start this patient on treatment. But if PCR is undetected, whatever ALT level is, but the PCR is undetected. Again, I repeat, PCR undetected. So you don't treat this patient and you do these 6 to 12 monthly follow-ups for this. So here it's simple. One end, you treat patient, and on another end, you don't treat patient. And the basic decision is by the PCR. PCR negative, whatever ALT level is, don't treat. PCR is raised and more than 2000 and ALT raised, then you treat. So what about in between? In between, there may be that the PCR is raised and more than 2000, but the ALT is normal. ALT is not raised. There may be another patient where the viral load is less than 2000 and ALT is raised. There may be third type of patient where the viral load is less than 2000 detected, but less than 2000, as well as ALT is normal. So these are the yellow groups. These are the red, you need treatment. Green, you don't need treatment. These are the yellow groups where you need to think something, to take some other factors into consideration. I again repeat, in between these two, viral load more than 2000, ALT normal. Here, ALT raised, but viral load less than 2000. And here, both the ALT normal and viral load less than 2000. So if your patient falls in this group, so what you do next? Here, in all the three, you look for these. Whether my patient has got significant fibrosis. Here it was F4. Here it is F2, F3. F0, F1 excluded. So if your patient has got significant fibrosis, and this data comes from the first step, or there are extrahepatic manifestations of hepatitis B infection, or there's co-infection with active hepatitis D and or HCV and or HIV, or if the patient age is more than 30 years, or if the patient has got family history of liver cancer or cirrhosis. So in this indeterminate group or the yellow group, you take these into consideration, any one of these: significant fibrosis, extrahepatic manifestations, co-infections, age, and family history of liver cancer. If none of these is present, don't treat. But if any one of these is present, you treat this patient. So when you follow this algorithm, you will be able to initiate the antiviral treatment in time in those who need it, and you will avoid wrongly starting patient on antiviral treatment, though it was not indicated. So I repeat again, in the first step, you take the history and clinical examination, you do the abdominal ultrasound, do some non-invasive tests, you check the PCR and it should be viral load, and then you note down when it is more than 2000, less than 2000, and the ALT level, it is normal or raised. And I have given you the normal limits for Pakistan. And then in the second step, and all these guidelines, which I shared with you initially, especially the last one, Chinese, the WHO, and the EASL, they agree upon this, that when this scenario is present, you start the patient on treatment irrespective of the viral load and ALT. But if any one of these, all of these are not present, none of these present, then you evaluate or you decide on the basis of the DNA and ALT. DNA more than 2000, ALT raised, treat. PCR not detected, and any ALT level, maybe you just do follow-ups. But if a patient falls in these yellow three groups, where viral load may be raised, ALT normal, viral load normal, ALT raised, are both not within the criteria of the treatment, then you look for these additional parameters, factors: significant fibrosis, extrahepatic manifestations, co-infection, age, or family history. If any one of these is present, you treat. If none of these is present, you don't treat. So this algorithm gives us the nice answer when to start antiviral treatment in my patients with age-based antigen positive report. Now coming to the second question, when to stop antiviral treatment in hepatitis B patient. To answer this question, I would like to give the reference of traffic signal lights, the red one, yellow one, and the green one. Red one is for pegylated interferon, and the yellow and the green ones are for the oral drugs. How? If a patient was started on pegylated interferon, so stop pegylated interferon after 48 weeks of therapy, and this is called finite therapy. So in case of pegylated interferon, treatment is stopped after 48 weeks. So the red light of the traffic signal applies over here. But if the patient has been started on oral drugs, either entacavir or tenofovir, so the antiviral treatment may be stopped in case of insignificant fibrosis. Your patient's liver was having F0 or F1 fibrosis, and you started that patient on the oral drugs. So here you can stop. This is the yellow group, provided in your patient the HbS antigen and PCR both has become negative, and patient has received antiviral treatment for additional 1 year after that. It means you started your patient, for example, you started your patient on antiviral therapy and he was having F0 and F1 fibrosis, and 2023, and when you checked his PCR or her PCR and HbS antigen, they were negative in 2024, and still they were having the insignificant fibrosis. And now they have completed another 1 year of treatment after losing HbS antigen and PCR becoming negative. Now in 2025, you can think about that, yes, you can stop this patient's antiviral treatment. This is the straightforward and simple condition in the yellow group of patients where there is insignificant fibrosis to start with, and still the insignificant fibrosis is there. But if a patient's HbS antigen is positive, but PCR has become negative, and the patient was HbE antigen positive patients, so here, if the patient has received antiviral treatment for additional 2 years, after that, with persistently negative PCRs, now you can stop. For example, your patient, you started the patient, he was HbE antigen positive chronic hepatitis B patient, and you started him on antiviral treatment in 2022, and he was having insignificant fibrosis. Next, in 2023, for example, his PCR became negative, but HbS antigen was positive, and then he received the treatment in 24 as well, and 23, rest of the 23 and 24, and now in 2025, we check his liver fibrosis that is still F0, F1, and his HbS antigen is positive, but his PCR is negative over last 2 years being on antiviral treatment. Now, and he or she is HbE antigen positive chronic hepatitis B. Now you can think to stop his or her antiviral treatment. And the third condition is in case of HbE antigen negative chronic hepatitis B, same applies, insignificant fibrosis, HbS positive, but PCR has become negative. And now here, the patient has received antiviral treatment for additional 3 years. And now you can think that you can stop this patient antiviral treatment. So I repeat, simplify it again, that provided the patient has got insignificant fibrosis to start with until now, and one condition is that both HbS antigen becomes negative and PCR becomes negative. Second is HbS antigen is still positive, but PCR is negative. So in the first scenario, the patient receives additional 1 year of therapy. In the second scenario, if the patient is HbE antigen positive, so he receives 2 years of additional antiviral therapy. And in the third, HbE antigen negative, the patient has received 3 years additional antiviral therapy. Then you can think about stopping the antiviral treatment. And this is the yellow group. What about the green one? Green one is then when the patient has got significant fibrosis or cirrhosis, F2, F3, or F4, you cannot stop antiviral treatment, and the antiviral treatment has to be given lifelong. So These are the principles that when to stop antiviral treatment. Peg-IFN interferon, you will stop treatment after 48 weeks. On oral drugs, and most of the patients, they are started on oral drugs. So in oral drugs, two groups, one where there was no significant fibrosis, F0 or F1, and the second group when there was significant fibrosis, F2, F3, or the patient was having cirrhosis. So in case of insignificant fibrosis, you can think about stopping the antiviral treatment. This is the yellow group. If the patient loses H-based antigen as well as PCR, irrespective of the E antigen positive or negative, you can stop treatment after giving additional 1 year of antiviral treatment. But if HBs antigen remains positive, then the stopping of the treatment depends upon HB antigen status. In HB antigen positive chronic hepatitis B, you give additional 2 years of antiviral treatment after the first PCR becomes negative, and in HBe antigen negative chronic hepatitis B patients, you give additional 3 years of antiviral treatment after the first PCR becomes negative. But if your patient was having significant fibrosis or cirrhosis, you need to give the treatment lifelong, long term, the green group. So with this, I thank you all for watching this vlog. I hope in this vlog, I have been able to give you the concise and crisp answers to these two questions: when to start antiviral treatment and when to stop antiviral treatment in chronic hepatitis B patients in the light of available recent guidelines, 2023 Chinese, 2024 WHO, and 2025 EASL guidelines. Professor Javed Iqbal FAROOQI signing off. Take care. Khuda Hafiz.